Right, perfect. All right, maybe we'll go ahead and get started here. I think people may still continue to kind of trickle in here over the next minute or two. Um, I'm excited to welcome Elaine Khoong here to present here at Health Informatics Grand Rounds. She's a general internist and clinical informaticist over at San Francisco General, and her interests include leveraging technology and implementation science to improve equity in the delivery of primary care, with a specific focus on chronic disease disparities in historically excluded populations as well. And much of her experiences are driven by her experience as a primary care clinician, serving diverse patients in safety net setting as well. Elaine, I'm going to go ahead and pass it over to you, and I'll be kind of moderating the chat as well. And unless you have kind of other preference, Elaine, we'll kind of hold questions towards the end.
Oh, that sounds great. I think my screen share should be set up. Let me get this Zoom menu off my monitor. Okay, and then folks are seeing some slides, I hope.
Right.
Okay, great. Thanks so much for having me today. I'm really excited to chat with you all. And thanks for the intro. So I'll just get started here. I realize I don't have a disclosure slide, but I have no relevant disclosures. So what I'm hoping to cover today is go over sort of, I think at a high level, making sure we're sort of on the same page, how we think about sort of digital health equity issues. And then I'm going to go through like a potpourri of different implementation efforts, specifically in our safety net setting, with some of our patients here in San Francisco, and just seeing sort of how I think that plays into how we think about implementing digital interventions. So this will be informatics focused, but it's like really implementation focused, drawing on a lot of the efforts that we've done over at San Francisco Health Network. And I see there's some, I think I saw Shoba as well. So people feel free to weigh in if you're more familiar with some of these efforts. So just to get started, this is a paper that we published with some folks over at UCSF, and what I want to highlight here is that I think when we talk a lot about digital health adoption or equity, there's a lot of focus on specifically what I would say sort of are like patient level challenges. So people talk a ton about digital literacy, or even I think some people talk about devices and data. And just as somebody who practices in a safety net setting, and I know lots of you out there also experience with this, I think it's really important to highlight sort of some of the challenges that happen at an organizational level, and as well as ones that are related to how like an intervention is designed. Just because some of these are really things you need to think of, I think on the front end as you're rolling out really some innovative, exciting things. And so, just for those of you who maybe have a little less experience with some safety net settings, I just want to go over some of the considerations that I think about, especially when we think about digital health implementation. Okay, so I think the first thing to highlight, and these come from some studies that one of my closest mentors sort of implemented, really talking to safety net leaders and thinking about how they think about innovation and digital health implementation. The first is that like innovation as sort of maybe viewed by somebody who is like a digital health leader or really thinking about innovative new stuff, maybe viewed differently by safety net settings. So I think one thing sort of this quote from a CMO at a public health hospital is sort of like there's a difference between innovation and academic setting where it's sort of focusing on the invention itself versus maybe in like in a more public healthcare setting where the innovation itself isn't really the invention, it's actually the implementation of it. So really acknowledging that it may not be a priority to sort of be the first mover, and that what is more innovative might actually be how you implement it in a different population. Another challenge I think that's worth highlighting or that's worth considering is that a lot of internal, and this is sort of something I hear a ton in our safety net system, is that I think internally developed innovations that sort of have better adoption. It's thought that they are sort of more considerate of the challenges faced by the medical staff or the folks who are practicing in that care setting, right? So you can see here this clinic CEO from the study where they interviewed some all safety net leaders. They say, you got to make sure you're asking the right questions. You got to innovate for those things that matter and try to understand the perspective of the medical staff. So really focusing on the acceptability, and also feeling like internally developed innovations are better to customize and meet demands of the system. So oftentimes I'll hear, like, oh, like this thing worked at UCSF Health, but like, is there something that worked at Alameda Health System or Contra Costa? So things that are more similar in terms of the resources from the clinic side, but also the patient side. This other quote I think is really helpful for highlighting that. Really, the thought that like here in our clinical setting, our safety net setting, we really focus on really getting to know the community more and outreaching, and so that we're a little bit more comprehensive about making sure that we meet the needs of our patients where they are at. I recognize, of course, when you focus on internally developed solutions, that there are sort of their own challenges related to sort of disseminating information, making sure it's sort of more generalizable outside of maybe that specific clinic where you're piloting. And I think in particular, as sort of a UCSF faculty member who's sort of working in a different healthcare system, it can be challenging, I think, sometimes for safety net systems to work with external collaborators who maybe don't understand the culture as much or who may bring expertise, but like they feel like are sort of outsiders. And so that is something that does, I think, come up and does um, pose challenges and requires thoughtful consideration of how do you develop that trust in the relationship with the folks who've sort of been there and entrenched sort of at the front line. And I think one other thing just to highlight here is just that sustainment is so key in implementation and safety net settings. So it's I think it's a challenge in any healthcare system, but in particular, I hear this all the time, and I see this all the time, just even in my short time here, is that it as this person says, it's not hard to get things kickstarted. The world's full of great ideas, but how do you make it work once the grant is gone? And building sustainment in is something that's really challenging. So so I want to sort of provide that as some background. And then the other thing that I think is worth thinking about as we think about some of these multi-level challenges is a framework that I want to bring from the National Digital Inclusion Alliance. So this is an organization that's been thinking about digital inclusion like way before COVID, before sort of most of healthcare had been thinking about it. And they focus on five pillars to digital inclusion, which I'll go through and I think are worth highlighting, not thinking of them only from a patient perspective, but also from sort of a healthcare system perspective. And I'll just try to provide some data to support some of that. So the first two pillars, which I think folks will largely be familiar with, is sort of internet access and device access. And just for those who are maybe less familiar with some of the data on this, um, one of the challenges in at least internet access is that we know that there are clear disparities that align pretty closely with historical disparities. So this is here in this area. You can see this map on the left is a traditional redlining map. And you can see those districts that are outlined in red, sort of back in, what was it, 1930s, look really similar to the districts that are red and orange here on the same map, which is looking at digital divide. So areas that have better access to high quality fast broadband are in green and yellow, and worse access is in red and orange. So really seeing that this sort of map exactly to where we've sort of historically had segregation and redlining, so similar districts. And this affects sort of not only patients, but just I think to the point about healthcare systems having their own device challenges. This is just a survey from our health network, and we just asked folks who were doing telephone visits and video visits, and this was pretty early during COVID, but how many of them were like using their own personal device because they didn't have a device supplied by the health center? And you can see it's like 60 to 70% were actually just using their own devices for their telehealth visits because they sort of didn't, we didn't even have that in place at the very beginning. And San Francisco Health Network is a pretty well-resourced safety net system. So again, just highlighting the device and internet challenges are not just only patient facing, you have to think about them sort of from the community level or the health system level. The next two pillars are digital literacy training and quality technical support. And I just want to tease them apart. They're two different pillars. I think lots of people who are new to the space, they think like some people just need help getting on the patient portal. Like we'd have them call IT support. And like the digital literacy part is more than just really providing support at the time of need. It's really about building people's skills and really empowering them to not only be able to like access the existing digital tool right now, but sort of new tools that are some coming down the pipeline, right? Like maybe a decade or two ago was like focusing on email, and now we're talking about like patient portals and the video visits, and then probably at some point it'll be like how to engage with an AI chatbot or something of that nature. And so recognizing that that is an ongoing training need is different than providing technical support at the time of service or the time of use. And again, probably not a huge surprise to folks here, but this is SF had an Office of Digital Equity that sent a survey out to a lot of SF residents before COVID, and they asked folks like who used the internet and then who actually had what they called basic digital literacy. And you can see here the way they define that is being able to do an online search, find a website, send an email, or fill out an online form. And you can see some disparities that, these gaps are probably smaller than they were before, but largely still exist. So in terms of internet users, which are any of those blue colors, you can see differences based on race, ethnicity, language preference, age, and income. And you can see there's a sizable portion of folks who were using the internet but really didn't have some of these basic skills that really allow you to leverage some of the benefits of the internet. And I think to highlight that, one of the challenges is that these patients are probably disproportionately served by safety net systems that are sort of under-resourced, understaffed, and therefore cannot meet sort of the digital literacy needs or the IT support needs of these patients. And just to as an example of that, again, we surveyed some of our clinicians and asked them like, hey, when you had a telephone visit or a video visit, like how much time were you as like a clinician spending trying to help the patient navigate their technology or provide technical support? And you can see in the video visit here, um, sorry about the coloring here, but like about a quarter of the clinicians said they probably spent more than 10 minutes. And as like a primary clinician, I only have a 20-minute visit slot, probably spent more than like half of their visit actually trying to support the patient with videos as visits because there was not actually any other support staff for that. And I know this is something that lots of healthcare systems struggle with, but I think I'm sort of just recognizing again that that is um, a barrier that exists sort of at multiple levels, not just at the patient level, but like, clinicians or clinical care team members may also need their own education on digital literacy or these new tools or have some IT support for their own needs. And then the last pillar is just focusing on really having accessible content or applications that's usable and usable sort of from the patient perspective, but also like usable for sort of each health center. So just as a quick example, and in terms of what accessible means, like we're talking sort of language access, which I think a lot about, just because I care for a lot of patients with a non-English language preference, but also those with sort of visual impairment, hearing impairment, physical impairments, just making sure it's sort of accessible to everybody. There's just again a sort of a quick example here. This was a study where they looked at a bunch of websites for community health centers and found that only about a third of them had translated any of their content. And actually, of this third, about half of it, it was just a direct Google Translate like API that translated the content. So not really a high quality translation. So just again, recognizing, I think, in terms of when we think about the levels of barriers, really that intervention design, that co-design part, like are you designing for the margins? And similarly here, I think this is, EHRs are something that I'll go into in a little bit, but they are, of course, like a tool that is not relatively new anymore, but sort of was introduced after the High Tech Act, right? And you can see just in terms of the accessibility or the availability, largely sort of probably due to cost or some IT infrastructure, you can see some differences sort of in the beginning, right? So certainly groups that are sort of public hospitals have sort of lower rates of adoption, and then you can see rural health centers, right? Just much lower rates of sort of being live in the beginning, and then health systems that were serving Medicaid patients. So again, recognizing that some of the differences we see in adoption are may not entirely be patient focused. They're related to sort of differences in where patients are acquiring their care. And then I think the last thing I just want to highlight, just sort of for framework for thinking through some of the case studies that I'm going to bring up, is this framework for thinking about how digital health interventions or just any sort of interventions in general might increase inequities. So this paper sort of says that like if you sort of have a baseline, the framework they propose is like you have a baseline health inequity, and then you introduce a new intervention. And this one was focused on informatics intervention. It was published in JAMA. If there's an unequal access to that intervention, unequal uptake, unequal adherence, or unequal effectiveness, all that does is sort of just exacerbates the pre-existing inequity. And just to sort of provide an example of this at a high level, I do a lot of work specifically in home blood pressure monitoring right now. And we can think about self-measured blood pressure monitoring or remote patient monitoring as a potential digital health intervention to address hypertension disparities. But if we think about sort of each of those steps along the way, there may be access challenges related to like, does the patient even have insurance to be able to see a clinician to engage in SMBP behaviors, or does their insurance even cover like blood pressure monitors, or do they sort of have the financial resources to access the blood pressure monitor? There might be different uptake, right? As we've talked about, historically excluded populations are disproportionately cared for by safety net systems that might be under resourced or understaffed, may not have the infrastructure to engage in remote patient monitoring. And so for there might sort of be unequal uptake. There might be unequal adherence. Maybe for some, the patients, their insurance card, for example, maybe doesn't have as good coverage of certain medications or the most effective medications. Or they're sort of working multiple jobs and it's really hard for them to engage in measuring their blood pressure consistently. And then last, there might be an effectiveness issue. We know, for example, with like pulse oximeters, they weren't validated in all populations. Maybe certain blood pressure monitors don't work as well with certain body habits or certain BMIs, or they're less effective or accurate. And so that might be another place where inequities come up. And so you can see with any type of digital health intervention, as you think about the implementation, there's so many steps along the way where it could result in worsening equity, or so worsening inequities. I'm going to go through just a couple of examples here. And I think I listed 4 case studies. I probably won't get through all of them, but sort of just get through what we have. The first one that I think is important. It's a little bit older, but just I think worth highlighting just because we rely so much on EHRs for I think implementation of a lot of interventions right now and also just data capture. Is I just want to talk about a little bit about some of the work we had looked at sort of EHR adoption and implementation specifically for performance reporting. So this is not my paper. I think I saw Julia on here. So this is Julia's paper, which I really like. It looked at and please correct me if I'm summarizing it wrong, but what she did was her and some of the co-authors, they were looking at some different types of EHRs that were in different hospital systems, and they looked at EHRs that were sort of less than basic EHRs, and comprehensive EHRs. And I just want to highlight two tables from this paper. I mean, the first is that you can see sort of the adoption rate for different types of EHRs, so comprehensive sort of being the ones with the most robust capabilities, if you will. It's certainly higher adoption of comprehensive EHRs in large hospitals compared to small hospitals, and then sort of urban ones compared to rural ones. But sort of for the purposes of this talk, I want to highlight sort of the critical access status here, right? Where you can see that safety net hospitals or critical access status as a proxy for safety nets. If they were critical access hospital, they're more likely to have sort of a less than basic EHR, and less likely to have a comprehensive EHR. And specifically, going into performance reporting, what they looked at is whether or not the health system or the hospital system had adopted a variety of performance measure functions. And so here they were just looking at the odds of adopting some 8 to 10 different performance measure functions. And the first thing here is you can see sort of having a comprehensive EHR was associated with higher odds of really having performance measurement, which is sort of one of the exciting things that I think folks were really invested in initially when EHRs came around. And again, the safety net status here, right? So being a critical access hospital, you had lower odds of having sort of these performance measurement functions adopted. And so what that looks like specifically is, just to bring this to California, is we looked at the most recent California Medicaid waivers, not the one that's currently in place right now, but this was the PRIME program, where basically health systems were it was pay for performance, and it largely became pay for reporting because of challenges with data infrastructure. But we looked at a handful of specific safety measures and focused specifically on ambulatory patient safety measures, of which there was a number, but just for the purposes of this talk, I'm going to focus on 3 in particular. The first is closing a referral loop. So I, as a primary care clinician, if I refer patients to specialists, did the specialist send any information back to me? The second was looking at follow-up of an abnormal fit. So that's like a colon cancer screening test, and seeing if normally after you get that test, if it's abnormal, you have to get a colonoscopy. So seeing if somebody actually got the colonoscopy after the abnormal test. And the third measure looked at if somebody had a high-risk abnormal mammogram. So when you get a mammogram, it sort of gets rated the sort of the risk of whether or not there's cancer, and BI-RADS 4 or 5 is really high risk, and so it needs to be followed up by a biopsy. And this looked at whether or not somebody got a biopsy within 14 days of that result. And what we did is that we basically just asked the public health systems in California that had to report these data, and there were 17 health systems, and 17 healthcare systems reported this specific measure. We just asked them sort of like, hey, what data did you actually report in year 1, and what did you report in year 2? And so you can see year 1 is in green, year 2 is in orange. But what we did in our studies is we sort of distinguished between the health systems that have what we called a comprehensive EHR, which we're really just having an EHR sort sort of the same inpatient and outpatient EHR, as well as one sort of for labs and radiology, sort of one that it sort of includes all the data that you might need for some of these performance metrics versus having a non-comprehensive EHR. And sort of one thing, sort of on average, the comprehensive EHR systems seem to do a little bit better than non-comprehensive EHRs. But what I want to highlight is that we looked at sort of two indicators of potentially having some challenges with data infrastructure or data quality. The first was like if a healthcare system simply could not figure out how to report data. And so you can see in two healthcare systems, one that had comprehensive EHR and one that had non-comprehensive EHR, actually just couldn't figure out how to get their data reported for year one. They just couldn't extract the measures and couldn't figure out how to report the data to the state. The second thing we also looked at is if a healthcare system had a big change in performance from year one to year two, such that it was very unlikely to be truly representative of a, either increase or decrease in performance, but more representative of sort of missing data coming in or sort of losing additional data, if you will. And that again, what you can see here is there were about 5 healthcare systems that met that criteria, and you can see sort of the big difference from the green bar to the orange bar. And a lot more of those were really healthcare systems that had non-comprehensive EHRs. So really highlighting, I think, again, that some of the challenges in data infrastructure, and this is 2017, so not that long ago, but we're relying on a lot of these data to implement, AI tools, clinical decision support, or even just like performance reporting or measuring sort of diagnostic errors. And so you can imagine some of the challenges in implementing some of this if you don't have great data infrastructure. This is sort of different metrics, but sort of largely same idea. Again, comprehensive EHRs, non-comprehensive EHRs. Comprehensive EHRs sort of did a little bit better, but again, missing data only from one of the non-comprehensive EHR systems, and then big data change performance or big change in performance from a system that didn't have a comprehensive EHR. So I think just want to start off with highlighting this as sort of one of the challenges is that oftentimes in safety net systems, not all, but in many of them, you're sort of working with a different data infrastructure ecosystem, or even just like the support needed to be able to extract data. That's something we heard from a lot of the healthcare systems as we were trying to collect some of these data, is that they actually had a hard time hiring or maintaining staff or IT teams that could actually pull these data in a way that they could use it for performance reporting. The second sort of case study in terms of digital health tools I want to talk about is telemedicine, which I think lots of people have talked about. Just want to highlight some of the things that we found in some of our studies and some of our research, and again, really focusing on challenges both from a patient level, but also from a safety net setting level. I think the first is probably no surprise to folks here is that safety net clinics did mostly audio only visits. So this is data that's pulled entirely from FQHCs in California, actually. And what you can see in the light blue, of course, is that the telemedicine visits, there's a huge increase in audio only visits. They sort of petered down, but they always stayed way more dominant than the video visits, which are just sort of in this darker color in primary care clinics. And one of the challenges I think that people have brought up was like, oh, safety net clinics is happening because they're serving different patients. And I do want to acknowledge that certainly is true to some extent. We have been serving some of our patients in our system. We surveyed about 170 patients and asked them a bunch of different questions about their access to devices, internet, their comfort with doing some different digital tasks, if you will. And so what we sort of found is, the 170 patients we've surveyed, about 15%, so like 13% here, specifically said they needed help always or most of the time with using their preferred digital device. So we said, like smartphone, computer, tablet, whatever you like to use the most, like, do you need help? And a fair number said they always or most of the time needed help. And then 30% said they needed help some of the time, right? So, like basically almost 50% of the patients are saying they need help at least some of the time. But despite that, what we found is that when we actually observe a lot of these patients, and we actually ask them, so we have them come in and we ask them to do a bunch of sort of digital tasks on their device. So bring in your phone or bring in your tablet, bring in sort of whatever you like using. And we asked them to do a few things. One was launch a video visit from a text message. So just really click like the hyperlink in the text message. The second was like go to a specific website, thinking about, like if you were to say like, hey, you need to sign up to my chart, you have to go to this website, or like go to this website to learn about X, Y, and Z. That was sort of the second task. The third task was if you already had an existing patient portal account. So we gave you a username, we gave you a password. Could you actually figure out how to log in into that patient portal? And then the fourth task was if you were at a website and you were told you had to sign up and your password needed to meet certain criteria, were you able to do that? So those are the four things we asked patients to do. And we sort of provided them increasing levels of support. So we sort of asked them to do it and we saw if they could do it independently. If they couldn't do it independently, we had created sort of standard handouts or videos in English, Spanish, and Chinese actually. And if they couldn't do it, we sort of gave them a handout or had them watch a video. And then if that didn't work, then we gave them sort of more support. So we gave them sort of the equivalent of like an IT phone call, so they could get like verbal support or they could get one-on-one sort of hands-on support. And then after that, we then saw like, okay, we gave you the one-on-one support. We showed you how to do it. Could you go back and do it on your own? Sort of replicating if, for example, a patient came in, we taught them how to log into their patient portal. Could they then go home and log into the patient portal afterwards? And so what you can see sort of in the bottom half here is that, a fair number, sort of two-thirds to three-quarters, were able to do it sort of these tasks independently or with sort of some pretty generic assistance like the handout or the video, which isn't bad. It's like pretty high rate, but larger number, about 10 here, and specifically visiting a website was really challenging for a lot of our patients. They needed some more additional support, like call an IT support, actually have a one-on-one digital navigator with them. And then at least 10% of our patients who did these tasks actually were unsuccessful. Even after like sitting next to them, showing them how to do it, they were unable to repeat it. And so, some of these are really, these aren't entirely telemedicine specific, but I think just highlighting that again, like digital literacy certainly is a challenge, and the extent of that it's pretty substantial. Like you can't just sort of like send them a tip sheet or send them to video. Like there's some people who really need a ton of help. And just to highlight that further, we asked about 200 patients who were scheduled for phone visits with us initially if they wanted to switch to video visit. And there's a bunch of things going on this screen, but let me just highlight a couple things. Like two-thirds were interested in switching. About 55% were able to sort of those, so 55% were able to complete a test video visit. So that was basically hop into a Zoom. We had lots of really motivated, interested med students in supporting at this time. But a lot of our patients had barriers, which, not surprising, sort of data, Wi-Fi, technology, access to device. But again, I think what I want to highlight is, in particular, this chunk here in on the right, which is that out of the people who were successful, 25% of them needed like in-person help from a family member or a friend who was actually on the other side of the phone with them. That was the case for 50% of the patients with non-English language preference, and then like a large 60% of those who are over 55 years old. So again, really, I think digital literacy challenges are substantial, and that they're not they are resource intensive at times to solve, right? Like having an in person there is a challenge. I do want to highlight though that these are not just like patient only barriers. So we had a pilot in a clinic where we were asking sort of medical assistants to sort of screen patients for access to devices and internet before enrolling them or assigning them for a video visit. And you can see this medical assistant, this quote here, saying like, well, I'll ask the questions about unlimited Wi-Fi, but I sort of feel like I don't really know what I'm talking about, right? So this is like training is needed not only for patients, but also for clinical care teams. And again, sort of, I think I showed a slide earlier, but again, like tech support also is needed, not just for the patients, but for the clinical care teams. And the reason I want to highlight some of those health system factors is that this paper from a group in Harvard, they looked at a bunch of their visits. They looked at in-person, audio only, and video visits. And they, find a lot of this sort of common disparities, but in yellow is what I want to highlight, which is that they found that like practices and clinicians drove, pretty substantial, almost two-thirds of the variation in video visit use, and it wasn't patients. So it really is, there's a lot of things that are implementation level that are really focused on what's going on in the clinics and clinicians, and I sometimes feel like we like to blame patients or attribute it just to patient factors, but there's a lot of things that are going on elsewhere at a different level. And just to highlight that a little bit further, we had a pilot in our OB clinic at San Francisco Health Network. So we got some funding to implement video visits even before COVID happened, and then sort of COVID happened, so it made it a little bit harder. But largely, what the funding supported was a project manager in the high risk OB clinic, which is HROB, and they were there on the ground to provide like at the elbow support for clinicians and clinical care team members to actually implement the video visit. And they called the patient, offered counseled the patient on it, and provided support on how to get them onto Zoom initially. And in blue is sort of like the percent of telehealth visits that were video visits. So in the beginning, when the project manager was there, a ton of the telehealth visits were video visits, and you can see sort of a huge drop off once that project manager is no longer in clinic. But what I want to highlight is actually the orange versus the green. So the green is overall the percent of video visits, or percent of visits that were video visits in our OMG clinic. So that's the overall OB clinic, where not everybody got the support that the project manager provided, but generally sort of it was similar staff, at least, and similar clinicians. And then in orange, this is actually San Francisco Health Network's behavioral health services. So same patient population, at least from a payer perspective, but what you can see is like a much higher rate of adoption of video visits for telehealth visits. And just one of the biggest difference was that the behavioral health leadership was really invested in getting their clinicians and their patients onto video visits. They really made sure to try to help overcome some of the device challenges, some of the internet challenges that were coming up, and made sure that everybody still went through training on how to offer this and develop workflows for doing so. And so again, we're talking the same patient population, probably even a more potentially more vulnerable patient population. The OMG clinics tend to serve a younger patient population, but really having that leadership buy-in was made a huge difference, and I think highlights how much acceptability is really important in safety net systems. I think one of the sort of interesting nuances that we found when we looked at our OB data is that a lot of literature has shown that having telemedicine visits or and phone visits in particular improve sort of the show rate for visits. And what we looked at is that for patients who were scheduled in our OB clinic, and especially telemedicine eligible patients, so that's like the blue dot, we looked at if they were eligible for telemedicine visit, did they actually schedule an in-person phone or video visit, and did they show up to that visit, sort of show up to the visit they were scheduled for? And what we found is that like relative to in-person visits, um, people who were scheduled for phone visit were more likely to no show, which I think we thought was a little bit surprising and was not, I think, our initial hypothesis about how that would go. And when we asked folks, when we interviewed them and asked them sort of their decision making process for choosing a type of visit, what we found is that like many of the reasons people chose a phone visit instead of an in-person visit reflected some of the challenges of just like making the clinical care, like sort of the many constraints and demands on their time. So you can see this patient says like, well, here this patient talks about like, I feel like it's better on the phone because by video I have to find a place to see the doctor where there's no people around, and on phone I can stand anywhere and I can be talking. So reflecting convenience of it, but also recognizing that like there's a lot of planning, more planning to be in a video visit, and of course certainly even more planning to go to an in-person visit. Um, Same thing with the other patient, at home I have to keep moving. It's rude to talk to someone if you're not sitting still. By the phone, at least I can still do stuff. And this patient says, calling was easier for me because I have too many kids to hold a video visit. And we heard this sentiment a lot. So like people who are choosing phone visits sort of had so many other competing demands. And I think I just want to highlight that, there's a lot of conversations about if phone visits lead to better or worse quality care. But that sometimes like the consideration is it's not sort of phone visit versus in-person visits, like phone visits versus perhaps like not coming at all. And teasing apart that nuance is certainly difficult, but I think it's worth highlighting when you have patients that do have sort of lots of barriers to accessing care or have lots of competing demands for their time. The next group of sort of digitally focused interventions I want to talk about is it's sort of just patient communication related tool, and specifically with a focus on patients with language barriers. So I know there's lots of clinicians here, but I think what I want to just highlight with this graphic here is that when you think about the challenges for patients with like non-English language preference, or even patients who are hard of hearing, we talk a lot about sort of interpreter use or interpreter access, but it's like always focused on the clinician and the patient interaction in a clinical care setting. And when you think about a patient journey from sort of like getting help, checking in, going into different care settings, going home, getting sort of care at home, one, there's interactions with tons of people who aren't just a doctor only. And sometimes those interactions are pretty, they might be perceived as low risk, like what time is my appointment? Where do I check in? Um, and then two, it happens lots of times outside the clinical care setting. Like I think about my patients who go to the pharmacist and picking up medications or getting their durable medical equipment delivered. And so there's so many places where there's a lot of friction in the interaction for patients with non-English language preferences. And so, and it's probably impossible to really have an interpreter or translator at every single one of those in those interactions or those encounters. And so just want to go through, I think, some of the challenges that come up when you think about sort of seeking health information, getting health information throughout this entire patient journey, and some of the considerations that come up. I'm thinking about how digital tools can sort of facilitate communication or potentially impede it. So one of the things that we did is that we used a it was like a couple of years ago. Basically, there was some funding to survey about 1,000 San Francisco residents using a survey that we called SF Hints, which is it's modeled after the National Cancer Institute NCI Hint survey, but we focused on San Francisco and we oversampled for low-income individuals, specifically wanted about a quarter sample from Black patients, and then a quarter that were Spanish speaking, and about a quarter that were Chinese speaking. And so, just want to highlight a couple of findings from those surveys. The first is that we asked people where they prefer to get health information from, which is really key part of getting maintaining your health. And we broke it down based on people who own smartphones and people who don't. And I recognize, certainly smartphone ownership is pretty high now, especially post COVID. But at least at that time, I think only about 80% of the population were smartphone owners. And first thing to highlight, I think, is that providers, like healthcare providers, for folks who didn't have smartphones, they're really interested in using that as a source of information. And then folks who had smartphones, they went to the internet, right? Like that's where they went for their source of information. But when we focus specifically on the provider delivered health information or provider delivered communication, um, we can see that folks with sort of no smartphones, especially sort of our Spanish and Chinese speakers, were really interested in just like having old school brochures. Like they just wanted handouts at their appointment. And then folks with smartphone owners, they were really interested in sort of email or text message, and brochures was actually still popular, but like nobody was all that interested in stuff coming through their patient portal, which is I think how we disproportionately deliver health information right now. And I think just sort of acknowledging probably some of the limitations and how that's used for communication. When we dug into specifically digital forms of communication or digital tool use for health related purposes, um, what we found is that again, sort of like 77% here own smartphones, 30% were emailing with their doctors, 20% were texting, um, but like a fair number were using sort of YouTube, and I think this is even higher now. But a lot of people were just like going to YouTube for their health information essentially. And in particular, let me jump over this here. I think one thing that was really interesting is when we looked at communication with clinicians, so focusing on the first three columns here. Uh, this app, I think we largely interpret that as patient portal. You can see who's using a patient portal with their clinician were people who received care at essentially this is UCSF, this is in San Francisco, or at Kaiser, or I think we had a couple of VA patients. Those are sort of earlier adopters, I guess, of digital technology. And you can see those people were using an app. But then, email was pretty common at the San Francisco Health Network is the second row. And then I think you see that sort of is that fourth row. So email was more common if you sort of were getting care at SFHN or UCSF, and then text messaging was actually really common also at SFHN. So really, I think just showing people are interested in using these tools, but how they're being delivered might vary and not be like the way that is most HIPAA compliant all the time. we wanted to see if any of this sort of changed after COVID, and so we used the HINTS data, which again is the national survey data, and we looked at if people use these digital sort of communication tools or digital health related tasks differently, sort of pre-pandemic. So we took the survey before the pandemic, and then we looked at the HINTS survey after the pandemic. And what we found is that there was like an increase overall in electronic communication after the pandemic, but that there was a significant interaction with education. Meaning specifically, there was an increase in electronic communication, but it was actually mostly only in college grads. So those were the folks, or I guess the folks like even beyond a college grad. Those are sort of the most educated folks, or the individuals who are using electronic communication more for their to engage with their clinician. And I think one thing just want to just highlight with that is I think it's not surprising. There's been a lot of publications, especially coming from folks here at UCSF, looking at the growth of patient portal messages. But uh, what I want to highlight is, this is at UCSF. We looked at a cohort of patients with diabetes, and we looked at both what we call between visit messages. So these are patient portal messages, but also between visit calls, so telephone calls between scheduled visits. And what you can see is sort of, it's not surprising here is this is the patient portal messages were sort of slowly creeping up, and telephone calls stayed the same. And that was at UCSF. But when we look at SFHN, what you can see is like the between visit messages sort of creeped up as well. But where we're actually seeing sort of more of the growth and certainly a lot more of the actual absolute numbers was in phone calls. And I feel like this is something that has not I don't know, like I don't think there's been as much attention, and just recognizing that as telemedicine has been rolled out, it's become more widespread. I think people are more accustomed to thinking about getting care between those visits. And what that looks like is different in different healthcare systems. We certainly had a growth of patient portal messages, but I actually think there's been a lot more telephone calls. And sort of recognizing that and accounting for that and thinking about it as a form of telehealth care, I think is important. The other thing I want to just briefly highlight before I go into foray on machine translation is that you know one of the challenges is for patients with language barriers is specifically like written communication. And we implemented sort of this, I would say, sort of like a relatively low lift intervention here, where um, on the hospital medicine services, we basically created a dot phrase where it was sort of standardized instructions, and we had it in English, and then we sort of translated it, pre-translated in Chinese, Spanish, and Russian. In this study, I only just evaluated English, Chinese, and Spanish. And what we found is that, and you can see before the intervention, the Chinese speakers had higher probability of having questions about their discharge medications. But then after we roll those instructions out, it closed that gap between our three language groups. So this was, a relatively easy intervention to implement that was meaningful in helping to address sort of disparities for a group that was having challenges with written communication. Um, one other thing I want to go into here in just communication, and I think I'll probably close up and open up for questions is uh, we did some focus groups with patients in English, Spanish, and in Chinese, and we asked them how they felt about clinicians engaging and using the computer during the clinical visit. And what this patient mentioned here was that, they were really, we talked about sort of their interest in seeing the computer screen. I think a lot of people felt like a lot of clinicians felt like, oh, well, if the patient doesn't read English, like, do they actually want to see the computer screen? And we actually found that even if folks had a non-English language preference, they were really interested in engaging in that triad, the computer screen, the patient, and the clinician. And you can see this patient sort of themselves brought up, and they're like, oh, I use a software to translate. I sort of face the computer, I use a camera and point to it, and I see the Chinese translation and I understand. And so this is a patient that's saying like they basically like downloaded Google Translate and like used the live translation feature on the computer screen, and really were excited about using it. And so, I think as I mentioned with the patient journey before, right, like it's pretty difficult to have interpreters or translators at every single point where you need to be communicating information to patients with a non-English language barriers. And so, I think there's been lots of interest in thinking about can we use machine translation. I'm recognizing I think some of the regulation challenges. And so just want to just go through a little bit of work that we've done in that space. The first is that what we looked at 100 discharge instructions in from UCSF and San Francisco General, and we just ran them through Google Translate in Spanish and Chinese. And you can see in terms of accuracy, it's better in Spanish than in Chinese. And sort of one of the key predictors of inaccuracy was spelling and grammar errors. And just to give you an example here, this clinician, has a small typo. It's like you'll be called an appointment for tomorrow ophthalmology. And in both Spanish and in Chinese, that just wasn't quite translated correctly, so that the patient actually knew what was going to happen. And I think probably beyond accuracy, what clinicians worry a ton about certainly is safety. And in this study, we found that about 8% of the instruction, or 8% of sentences were translated in a way that could have potential for clinical harm. And that was the case for about 2% of Spanish instructions. And there were a couple of significant predictors of harmful inaccuracy. So poor readability, a focus on follow-up instructions, if there's medical terminology, again, spelling or grammar errors, and then using sort of colloquial English terms. So just to give you an example of some of those concerns, the first example here you can see the sentence is like hold the kidney medicine, and in both Spanish and in Chinese that was translated as like keep it. So it's like to continue the medication, which of course is like the exact opposite meaning. And if somebody has AKI, that could be very, very dangerous if they thought they were supposed to continue the medication. The last example is sort of just going sort of at a spelling or sort of a typo issue, right? You can see you have a low back stain. So in English, like I would know that clinician meant like a strain, but then when it went through a machine translation, they actually translated stain directly and said you have a low patch on your back or you have a low back spot, right? So it's just challenges in getting that machine translation correct. So one of the things that we've been doing, working with a group at Berkeley, we're trying to see like, are there ways to increase the transparency on the quality of the machine translation, which is something that I think we are hearing a lot about, certainly like with AI use, right? Sort of increasing transparency on the quality. And one thing that what they propose is basically two different ways to try to provide insight to the clinician about the quality of the machine translation. The first was using quality estimation algorithms, so pre-existing tools, and just providing a qualitative assessment to the clinician about how likely that machine translation is accurate. So they did here was they basically said, the translation preserves only some of the meaning of the source, but misses significant parts. And then I think another example was like it preserves almost all the meaning, it preserves some of the meaning. So they sort of gave like 3 or 4 categories qualitatively. The other intervention they tried is back translation. So just taking the content, putting it through Google Translate, and then back translating it to English so that the clinician might have some sense of if the machine translation algorithm is struggling with that content. And what they found was that the quality evaluation model output, so that's the one that says like it retains some of the meaning or retain none of the meaning, it makes clinicians better at deciding when to rely. So the way we did this study is that the outcome was confidence weighted accuracy. So they asked clinicians like, would you rely on this? Like, would you rely on this machine translation if you gave it to a patient, and how confident are you in your assessment of relying on it? And what you can see here is the significant sort of star here, right? Is that for quality estimation, the clinicians sort of from their baseline assessment to the if they were in that experimental condition, they sort of had greater improvement in their confidence weighted accuracy. And then that was significantly different than the experimental group in back translation. But the other thing they found too was that the back translation condition, in that condition, clinicians were better at recognizing if there was like a harmful error. So here you can see the in the experimental condition for the back translation, clinicians were just better at recognizing when there was